Thanks, Joe. I know we heard yesterday that we're not supposed to start our talk with an apology, but I feel the need to say, and I'm sure some of the other speakers today felt the same way, I had to go home last night and take a whole lot of words out of my slides, but I wasn't organised enough to give my slides, for Gracie Leo to get the opportunity to give my slides her treatment. So, this is what I'm going to cover in my talk. That's my nephew Angus in the fridge. Nothing to do with the talk, but really cute photo. Just really my background. So I'm going to start with that really. I'm a general paediatrician. I finished my training in 1999, and I did half my training at each of the two children's hospitals in Sydney, and I had a sort of in the middle of my training, I went to Africa for 6 months and worked in Tanzania with the Rwandan refugees, so I got sort of a different side of life and a different experience there. And when I started work as a consultant, what I've done is I've worked in this radius around Sydney and these large outer metropolitan hospitals. Initially Campbelltown, where I worked with David's brother, and Wyong on the Central Coast, and I've been at Wollongong for the last 5.5 years now. And in each of those units, I've established or been part of ambulatory care services. It's not something I sort of set out to do, but what happened was at Campbelltown, my job was based in emergency. The situation in Campbelltown when I started there was they had no emergency physicians, really busy emergency department, lots and lots of paediatric presentations. And I'd rung my buddy Andrew McDonald, who had trained me as a registrar, and I remember saying to him at the end of my term, which was in 1992, feeling very old, joking as he did my term appraisal, saying, "Oh, save me a job for when I finish my training." And then at the end of my training, I'd met my husband, we were getting married and moving out to Campbelltown, and I picked up the phone and rang Andrew and I said, "Andrew, I'm getting married and moving out to Campbelltown, is there any likelihood of a job?" And he said, "Oh," and basically, to cut a long story short, they couldn't find an emergency physician, but they had lots of kids coming to ED, so they said, "Why don't we put a paediatrician in ED?" And that's how I started there. So my job initially was very much acute care paediatrician in the ED. Campbelltown Hospital has a really big, I'll just come back for a sec, a really well-established big adult hospital in the home, ambulatory care service. They had an innovative general manager, and basically I got to put up my hand and say, can I just copy what the adults are doing and introduce it to paediatrics? And that was the beginning of my journey into ambulatory care. I don't think I can give a talk on ambulatory care without spending a couple of minutes just talking about definitions and acronyms, because the term ambulatory care is really non-specific and means different things to different people. For the context we're talking about here, I'm really talking about illness care, so children with acute illness, but also chronic and complex illness, because those kids come in and out of our units all the time and they fit well with ambulatory models, including kids who have a monthly infusion of Intragam or things like that. And that's different to what I would call wellness care, which I'll say is, as an example, a community paediatric clinic where you're doing developmental assessments, or your sort of general paediatric outpatient clinics. I'm not really covering that in this discussion, but I guess I'm putting that caveat in because for some people the term ambulatory care encompasses those things. I'm not going to go through the acronyms other than to say that there's lots of them. And you'll find all sorts of different units. I think hospital in the home has become a pretty standard accepted acronym, and so when you hear people talking about HITH or read about it in the literature, it's pretty standard. That's become the term we use for hospital in the home. Going to the literature, there is one fairly useful definition I think here. This comes from a UK document which you can just you Google and it comes up as a PDF. And they're talking about the UK context where there's well-established short-stay units, paediatric ambulatory care services in many, many units. And this document was written in 2009 where they describe various different models of care, and I think that's quite a useful definition if you're trying to come up with something. That's the stuff we're talking about. So it's children with acute illness, injuries, referred by GPs or community nursing teams, a place where they can be seen and sorted without being admitted to hospital. So a little bit of history, and again, this is not a detailed literature search review, and there's probably articles earlier than this, but my interest in ambulatory care started in about 2000, and I did go to the literature to see what I could find. Couldn't find lots of references. Gary Brown and Tony Penner had written this article in the archives in 1996 where they're saying emergency short stay units, that's the future. And one article that really did inspire me was this one by Maud Meets, who's someone who works in New Zealand now, but she it was almost an opinion piece article talking about ambulatory care and short stay. And I still remember when I read her article, a light bulb sort of going off thinking, that's what I want to do here at Campbelltown. As I mentioned before, I got to ride on the coattails of a really effective, established adult ambulatory care service and copy everything that they did really well and learn from them. And that's how we got started at Campbelltown. But I also think I need to point out that most paediatric units, and I'm really talking about the non-tertiary setting at the moment, we all do ambulatory care, whether or not we've actually got a PAU or a PACS service. And that's those kids who come into our ward oncology kids who come to have their ports flushed or bloods taken or things like that. Or sometimes kids come back for wound care. A lot of us are doing ambulatory care, not all of us are doing it in a designated unit. Where things are up to, talking about the New South Wales context, this document is currently it's sort of in the draft for comment stage, and I'm expecting it to be published by the end of the year. And I can look back and say in 2000, when I first started to have an interest in this, there was really nothing like this, and so New South Wales is certainly taking a statewide approach. And this is important in particularly in terms of data collection and trying to make sure we're comparing apples with apples when we're talking about what different units do. So I wanted to give it a bit of clinical context. So just to give you a few cases to describe how ambulatory care works. So a 13-year-old girl admitted to the ward. She's got known congenital heart disease, has got a shunt, but doesn't have any other sort of metalwork or hardware in there, but she's had that shunt since infancy, and she's come in with unexplained fevers, no clear focus, and we've had a phone call from the lab saying the 2 sets of blood cultures are growing viridans strep, and we've discussed her with the cardiologists. They've done an echo. They can't see any vegetations, but they really do suspect she's got endocarditis, and they're recommending she has at least 4 weeks of intravenous penicillin. If she was an adult, I'd say in most of our hospitals, just no hesitation. It's straight referral to the hospital in the home team. Someone puts a PICC line in and they go home and have intravenous penicillin through a Baxter infuser, high-dose penicillin. They'll have weekly medical review and blood tests done, and it's very standard. For paediatrics, it's quite variable whether or not we've got access to that service. And for some units, it will be a case of, look, she's 13, she's 60 kilos, she's physiologically an adult, lots of sucking up to the adult hospital in the home team to say, please, will you guys take on this patient? In other units, if you're lucky, we've got a paediatric hospital in the home team who can take her on. But she's a very clear, makes a huge difference to that kid and her family. 4 weeks of antibiotics at home versus 4 weeks of antibiotics in hospital makes a huge difference. And when she's having her home treatment, she can go to school. They can time their visits around school and things like that. 9-year-old girl in the emergency department with pyelonephritis. So she's got loin tenderness, she's got positive urine, she's got raised inflammatory markers, but she's been observed for a period. You're happy she's not septic or shocked. We can do ambulatory management for her and send her home with a cannula in after having a dose of gentamicin and a dose of ceftriaxone, and she can have daily antibiotics for the next few days and have ambulatory management and not be admitted to hospital in the first place. 2-year-old with gastroenteritis and borderline hydration. This is the little one who's been in ED, having a trial of fluids, but not very compliant and not very successful. If you've got a short stay unit, you can nurse her in the short stay unit, give her nasogastric rehydration or intravenous rehydration, and get her home with the nasogastric or the IV in place to sleep in her own bed overnight. So I call it filling up the tank. So fill up the tank, get them well enough to be able to go home and sleep in their own bed, and then there's a planned review the next morning, either with a nurse who does a home visit or they come into your acute review clinic. 4-year-old with pneumonia referred by the GP. One of the things, and I will talk more about it, is I really would love that kid not to have to go through ED. They've already seen a doctor who's treated them for over the last couple of days, but they're still febrile and not right. The doctor is saying they need intravenous antibiotics. If that child comes to ED, they'll see the triage nurse, they'll wait for quite a while, then they'll see the junior doctor in ED, they'll wait another few hours for senior review. Eventually the paed reg will see them and they'll say, yep, you've got pneumonia, we're going to do intravenous antibiotics. You can bypass all of that if that child could come straight to your assessment unit. And then they are often suitable for ambulatory management, not always, but I'm sure you've all seen the kid in ED who comes in with pneumonia, flat, lethargic, really unwell looking. Put the drip in, start the antibiotics, give them some intravenous fluid. 3 or 4 hours later, they are bouncing around, totally different child. And it's often that the dehydration was making them flat, you've rehydrated them and they feel better. One of the challenges with that sort of kid is if you set them up right at the beginning of the ED stay and you say they've got pneumonia, they're going to need to stay in hospital, it's very hard to actually, for me, then come along as the paed and say, actually, we could do ambulatory management and get you home, because the parents are going to go, but that other doctor said he needs to stay in hospital. So the better approach from my point of view is to take that child who's looking quite unwell at the beginning and say, look, this is what we're going to do. We're going to put the drip in, we're going to start some antibiotics, we're going to watch what happens over the next few hours, and then we'll make a decision about whether or not you need to stay in hospital or whether we can do ambulatory care. And the last one there is the child and family nurse who rings you. The paed regs get this all the time. They get phone calls from the midwives or the child and family nurses really worried about this baby who's sleepy and lethargic and jaundiced and not feeding and clearly needs medical review. And again, I'd love to find ways for that baby not to have to go through ED. So what are the challenges you encounter with this concept? Data. It's really difficult capturing a patient journey accurately when it can involve an ED visit followed by short stay, followed by going home, then a nurse phone call the next morning, then coming into an acute review clinic, then maybe a home visit. There's a whole lot of aspects to that care, and our data systems in hospitals are kind of designed either to be inpatient systems, so we capture an admission or an episode of care, or outpatient systems where we capture a non-admitted patient occasion of service. But it's really difficult sometimes when you've got this patient journey that crosses the spectrum. I haven't solved the problem, but data is a challenge. And that leads to the apples versus oranges thing. And I, not to sound bitter and twisted, missed out on some hospital in the home funding for our service recently because we were only capturing true hospital in the home activity as hospital in the home. So what we were saying was the child, if they hadn't been receiving the service, would have been admitted to hospital. But because our numbers were so much lower than a whole lot of other units, we didn't get funding. And I'm sure a lot of the activity in the other units was a baby with bronchiolitis who got a phone call from the nurse the next morning, having gone from ED the day before, and we wouldn't have counted that as HITH in our unit. Turf wars. So who looks after these patients? ED or PEDS? Who's responsible? And nursing versus medical. So one of my pet hates is what I call the magic medical blessing, where a very competent senior nurse, absolutely capable of making the decision that the child's right to go home or needs admission, can't do anything until the doctor comes around, who may be the PGY2 RMO who's very inexperienced and is just going to ask the nurse what they want to do anyway. We've had some, I've put there acute review clinics deferring clinical decision making. So an unwanted side effect of setting up an acute review clinic. So a child goes home from ED and comes back to the acute review clinic the next day is, I think, the temptation for the Paed Reg, rather than go and see and sort the kid and make the decision, to defer that to the next day. So to say on the phone to the ED, yep, sounds good, just refer them to the acute review clinic. Kid comes to the acute review clinic the next day, something's been missed or not right, which if the registrar had gone down and seen them in ED the night before, it would have been seen and sorted. So just to make sure you've got systems in place to try and reduce the chance of that happening. We've had some problems with clarity over senior medical governance, particularly with kids, Joe's laughing, I'm sure, particularly with kids who might have come back to the acute review. They were in ED the night before, they've come to the acute review clinic, been seen, the nurse rings them the next day, they're still not right, so they come back the second day. And then the doctor who's on that second day gets rung about them because someone thinks they need admission or things like that. And they'll go, why am I being asked about this kid when they've been being under the care of our service for the last 2 days and I wasn't on call 2 days ago? The point I make sometimes with that situation is if that kid was in ED, you haven't been told about them. As the paediatrician on call, you don't get rung about every kid who gets seen by our registrar in ED. And if our service didn't exist, they probably would have bounced back to ED and you would be being rung about them today as the person on call, but that doesn't always, that's been a challenge. So just if you're setting up a service, work out how you're going to do your senior medical governance. And for us, it's if they have more than one visit, it has to be discussed with a consultant, so someone needs to know about them. Hospital in the home. As I said, we just missed out on funding in our unit because we didn't have big enough numbers. And the point that I made is, as a regional, we have a 24-bed paediatric inpatient unit, sort of pretty standard level 4, sort of big outer metro or regional hospital. At any one point in time, I'm going to have maybe 1, 2 or maximum 3 kids who might be suitable for HITH management on my ward. I'm never going to have enough throughput to run a standalone paediatric hospital in the home service. And that's different to the adults who have, you know, well-established hospital in the home services. So do I try and run hospital in the home out of my children's ward, or do I ask the adult service to take on the occasional child? My preference is very much for paediatrics to be doing it, but it's a challenge. It's why I think it needs to be integrated. And vascular access. So these kids who have 4 weeks of antibiotics need a PICC line. We have trouble. Children's Hospital in Sydney not at all keen about putting in a PICC in and sending them back out to a regional unit. And so it's almost like each unit needs to come up with their own local solution. We have a fantastic adult vascular access team in our place who their job all day, every day is to go around putting PICC lines in. And so we've sort of developed a partnership with them that says, we'll hold your hand, you hold ours. Can you please help us put a PICC line in this 9-year-old or whatever it is we're asking? And that's working well for us at the moment. Does it save money? The bean counters prick up their ears when you talk about these models of care and they go, beauty, we can close our children's ward. And the answer is, no, you can't. And the actual reality is hospital in the home or ambulatory care, it's really only going to save lots of dollars if you can actually close inpatient services. So if you can reduce your inpatient side to bolster your ambulatory side, then in theory you can save money. But if nothing changes on the inpatient side, then no, it's not going to save lots of money, and you're going to have to find the resources to run that ambulatory service. Doesn't mean we shouldn't do it, because I think it's got to be driven by patient-centred care and what's right for the patients. And we know from our patient satisfaction surveys and things like that, families love ambulatory management if it's available and an option. We do save money on transfer costs. So Wyong on the Central Coast, there's no paediatric inpatient unit there. So, and they run a really busy ED, more than 50,000 adults a year. I'm looking to Pippa, how many? It's lots, huge numbers, at least 12,000 kids per year to their ED. So if a kid needs admission, they've got to be transferred down the road to Gosford, and that often involves an ambulance. If you run a good ambulatory service at Wyong, we've shown the vast majority of kids with acute illness could be managed through the ambulatory service, and that did save on those transfer costs. Okay, some lessons learned. I've never tried to talk a parent who is anxious into going home because they bounce. So that child with pneumonia that I described, who was really unwell when they came in, looks much better now. I'll go and have a conversation with the parents. I'll give them ambulatory care as an option. But if they say, no, I'll be terrified, I'd just spend the whole night sitting beside the bed watching her breathe or something like that, always admit those kids. Don't try and talk them into going home. You've got to be flexible, and you've got to have good communication, and you've got to make sure those safety nets are there. And by that I mean, if you've got a kid at home having ambulatory management and they become unwell, the parents have to know who to ring and contact. And it can't just be default, come back to ED if you're worried. It needs to be, this is the number to ring. And if they need to come back, it should be to your children's ward. And to reassure everyone, the ambulatory care, you will never lose our inpatient units. I do think we should have fewer, bigger inpatient units and run ambulatory services. But, yeah. So I'm not going to dwell here. My ideal model of care, close to but separate from ED. So I want to give ED, I want ED to be able to focus on the see and sort acute assessment, and so pull them out of ED, at which point they're no longer ED's problem, paediatrics are looking after them. Your model's got to operate 7 days a week, extended hours. You've got to have flexible staffing that follows the patient flow. So ideally it's integrated with your children's ward. If the inpatient side's busy and the ambulatory side's quiet, the staff are down the inpatient end and vice versa. It's got to have all those things. I reckon these models of care lend themselves very well to experienced senior nursing staff who I want them empowered and able to initiate and do stuff within a scope of practice with a safety net underneath them. I think paediatric hospital in the home should be being provided by paediatric teams, and I'd rather do that than have the adults have to do it. But you need lots of partnership. And the example I'd give would be my 13-year-old with infusers. The adult HITH team, they're the infuser and PICC line experts. And so if my nursing staff and paediatrics need assistance with that, the adult guys will give us help. I've talked about that, I think. I'm not going to dwell on this, just that's straight out of the document that I mentioned before, that's UK guidelines. And the only caveat on that is how applicable it is to the Australian setting. So there's no place like home. That's my greyhound relaxing on the lounge. And so that's what families are often like when you give them the opportunity to go home. I have to speak up for advocacy for paediatric services within all of our non-tertiary settings, because sometimes we're just a tiny pimple on the backside of a really big organisation, and we need to keep on advocating and speaking up. And partnership.